Okay, good morning, everyone. Thanks for attending this morning's Echo Rounds. Today we have Sivi, one of our C2s, Dr. Sivisan Suntheralingam, to present a topic on echocardiography in the aorta, often the forgotten chamber of the heart. So Sivi, if you want to take it away, tell us about the aorta.
For sure. Can everyone hear me okay and see the screens okay?
Yep, you look and sound great.
Perfect. So thank you everyone again for the opportunity. I'm Sivi. Sorry that I couldn't make it in person. I got quite sick and so wanted to make the most out of the opportunity, and that's why I'm presenting via Zoom here. So the title of my talk is Echocardiography and the Aorta, Fundamentals and Beyond. I wanted to make this a relevant review, as well as particularly for our C1 colleagues who are starting their scanning blocks or who haven't had their scanning blocks just as yet, to go through some of the fundamentals with them as well. And so the objectives in light of that is review of the anatomy, as well as the steps for acquiring the images, as well as the measurements of the aorta. Next, I wanted to review some of the guidelines on monitoring and intervention for aortopathies. And lastly, reviewing some of the acute aortic pathologies and the role for echocardiography in these cases. And just to put into a little bit of context into why I chose to talk about this, actually occurred on call when I met a gentleman in his 60s who came in as a code STEMI. He had some coronary risk factors, presented obviously with ST elevation, a troponin rise, and chest pain that was relieved somewhat with nitroglycerin. Put a probe on his chest and saw a dissection flap in his aorta. And we obviously admitted him, managed him as a dissection, involved cardiac surgery, who urgently took him to the OR, and he had dissected his coronaries as part of this presentation as well. And so having such a versatile and accessible tool with echocardiography that we reach for as our firsthand seeing patients and emerge the units, and being able to have acute aortic syndromes, for example, early on our differential, and being able to identify this with imaging can have a huge impact on the clinical trajectory and outcomes for our patients. And so that's what prompted me to learn a bit more about this and also present this as a review for everyone here as well. So just some of the basics, just to set a baseline. The anatomy of the aorta. So going through this in broad strokes, we have our aortic root that you see at the bottom here. I'm not sure if you can see my cursor. We have the right and left main coronary arteries coming out from this. We have the ascending aorta. We then have our aortic arch and the main vessels supplying the upper limbs as well as the head, with the brachiocephalic renominate, left carotid, and the left subclavian. And then we have the descending coronary artery going down as such here. It will become more relevant when we talk about the aortic layers with aortic dissection. And so just to set that as a baseline with everyone, the three main layers to talk about from the inner surface that's in contact with the blood is the tunica intima. We then have the muscular tunica media, and then more of the connective tissue layer with the tunica adventitia, which has some of the internal blood vessels, such as the vasa vasorum, as well as endothelial cells, amongst others. And then just going down a bit further in terms of a cross-section view. So with the right figure here, you can see in light of the anatomy of the aortic valve with the non-right and left coronary cusps and how the coronary arteries come out from this. And on the left is just a picture that we see on cartoon of the peristernal long axis view. And you can see an A representing the LVOT, B representing the sinotubular, the aortic root, and C talking about the sinotubular junction, and D referring to the ascending aorta. So going through the basics in terms of image acquisition and what views we get to visualize the aorta. So this is the peristernal long axis view. The probe is placed at the second intercostal space at the patient's left sternal border. The probe marker is facing towards the patient's right shoulder. And this is a cartoon as well as a still image showing the anatomy that we see. So going from the top down briefly, you have the right ventricle, you have the anterior septum, the LV, the mitral valve, the anterior and posterior mitral leaflets, infralateral wall, the coronary sinus, and the descending aorta. Of relevance to us here is in this region, so we have the aortic valve, and then we have the aorta, just as you see here, with the aortic root, the sinotubular junction, and then the ascending aorta coming up a bit higher. In terms of our conventions on how one measures and takes the dimensions for the aorta, again, just as a review for our C1 colleagues, we take the personal long axis view, we zoom, and the convention is an end diastole, leading edge to leading edge, which just refers to the edge of the aortic wall that's closest to the probe. And so you can see here pictorially represented that is covered in our dimension, going just before the edge away from the probe here. And I'm just trying to represent that. You can see in the still image here, the aortic valve is closed. We're just at the cura, so an end diastole, and those are our conventions for making the measurements, and that's what we refer to as leading edge to leading edge at end diastole. Oftentimes, we may not be able to see the ascending aorta in that initial personal long axis view, and so you may need to go up 1 or 2 intercostal spaces to visualize more of that ascending aorta. And that's what I've tried to find in terms of a cartoon picture, as well as a still image to show what that image would typically look like. And this is to show you, again, that leading edge to leading edge convention and how that measurement is done for the ascending aorta. And in this case, we have a diameter of 4.2 centimeters. Other views to visualize the aorta. So we have the suprasternal view, the probe placed in the suprasternal notch, slightly tilted to the left, where we can see the ascending aorta, the aortic arch, as well as the descending aorta, and then the main blood vessels coming off of the arch, similar to what we saw in the anatomy picture. We then have the long axis apical view, or 3-chamber, with the mid-descending thoracic aorta, as you can see visualized here. And then the subcostal view, where we can visualize the abdominal aorta in a similar position, slightly angulated to the patient's right shoulder when we're looking at the IVC otherwise. These are just some reference values from the guidelines that I have here. This is what is referred to when we're interpreting echocardiograms in the lab. And so these are aortic root dimensions in adults with absolute and indexed values in men and women. And the below table shows the normal aortic root diameter, or men and women with a BSA of 2 and a BSA of 1.7 respectively at the different age cutoffs respectively here as well. And this is something, as I mentioned, that we keep in reference while we're reviewing echocardiograms to see if the dimensions are within normal or acceptable limits for this patient. So the main references that I used was the 2015 ASC guidelines, the 2022 ACC-AHA guidelines, as well as some other papers talking about in terms of review of echocardiogram as well as multimodality imaging to assess the aorta. And so just to establish some set of baseline definitions, a dilated ascending aorta is defined in a space of 4 to 4.4 centimeters. And what's referred to as aneurysm is greater than or equal to 4.5 centimeters. And the term dilation is preferred to the terminology of ectasia. And some of the reasons noted in the review in the literature was that there's a lack of uniformity in the use of the term ectasia in image interpretation. And often ectatic aortas refer to some parts of the aortas that can have outpouchings where the diameters can be in the region of aneurysm. And it can cause some confusion in overall interpretation. And so that's why the term of dilation is preferred over ectasia otherwise. Next, I wanted to go over the concept of normalizing ascending aortic diameters for body size. And so the first concept that came up is utilizing a Z-score. And a Z-score is essentially also known as a standard score, which talks about how far your value is from in terms of how many standard deviations away you are from the established mean. This is routinely used in the pediatric population where there are quite a lot of fluctuations in weight and height in these patients with their age. Nomograms have been established correlating BSA, or body surface area, and the aortic root diameter. Some of the limitations with this, by relying on the body surface area, some notes indicate, there's multiple formulae to calculate, and so it can possibly lead different results for the same patient. There are multiple Z-score calculators, and each of these can perform differently in the same patient. And of relevance to us is most of the literature on the natural history of aortic syndromes are based on aortic diameters, and so the reports of outcomes based on Z-scores are a bit limited in that case. The next concept here is the aortic size index and the aortic height index. And so this is where the aortic diameters are normalized using a ratio of the aortic diameter to the body surface area or to the patient's height. So with the ASI, again, the aortic diameter in centimeters over the body surface area, has been noted to be a better predictor of adverse aortic events than diameter alone. However, it's a little unclear regarding what that impact is on aortic diameter, as you wouldn't really expect a patient's aorta to significantly fluctuate with the patient's weight going up or down per se. The next concept is the aortic height index, and so that was thus examined in light of this, where they looked at the aortic diameter over the patient height, and it was noted to perform just as well as the ASI, with the benefit that it was simpler to calculate. And this concept of looking at the cross-sectional area to the height ratio, and this comes up in the guidelines, and we'll talk about it, especially in light of Marfan syndrome as well. The cross-sectional area, so squared centimeters, over the patient's height in meters. Initial studies used 10 as a threshold due to increased risk of adverse events, and later studies using this CSA to height ratio of 10 of greater than equal to 10 as a threshold for which was predictive for increased risk of complications, including dissection in these patients. Now, this is a figure that we see when we're interpreting echoes in the lab, and I've been using this in my first reading block here at St. Mike's. And so the concept here is you have your sinus of Valsalva, diameter in centimeters on the y-axis, and each of these graphs represent different age categories, so 1 to 15, 20 to 39, and age above 40 with C. And the idea is you take the body surface area for your patient, you then draw a straight line up, and this refers to the normal range in terms of the lower limit and the upper limit of normal for the sinus of Valsalva diameter for that patient here. So now that we went through the anatomy, we went through the measurements, how to acquire the measurements, and some of the strategies to normalize or standardize the measurements that we see for our patients. I'd like to talk a bit about some of the pathology now, specifically going into aortic aneurysms. So with aortic aneurysms, most of the dilatation, about 60% of cases, occur in the proximal aorta. And so TTE, or transthoracic echocardiogram, is an excellent screening modality, be it for Marfan's patients, bicuspid aortic valves, etc. Transesophageal echocardiograms are superior to assess aneurysms at the aortic arch and the descending aorta. However, it's limited when we have tortuous aortas, and that's where the role of MRI or CT allow for better visualization. This is a still image just to show some pictures to those who aren't as familiar of a sinus of Valsalva or aortic aneurysm. So this is a peristernal long axis view. Of relevance to us for the anatomy is the aortic valve here. And you can see that leading edge to leading edge convention is used for the measurement. And we have a measurement of 9.4 centimeters, so quite an enlarged aneurysm that we can see here. And when color is applied, you can see the significant aortic regurgitation in this picture. This is just a clip that I had to show for those who aren't as familiar what an aortic aneurysm would look like. So again, a peristernal long axis view. And then this is that view going up 1 or 2 rib intercostal spaces, to visualize that ascending aorta. And I'll just clip that again here. So we would measure here and going up to look at the ascending aorta, which we would measure like so. And in this patient, the ascending aorta was about 5.5 centimeters. In terms of our categories into how to delineate what the cutoffs are and when to intervene for patients is based on the following. So one criteria are patients who have no family history and are gene syndrome negative. The next are patients who have a positive family history but are gene syndrome negative, which are the non-syndromic hereditary. The third criteria are those who have syndromic, so Turner's, Marfan's, Louis-Dietz, or those without a syndrome but have a pathogenic gene variant that's testing positive. And the last criteria is that of bicuspid aortic valves. And so for those not familiar, you're maybe wondering, why does all of this matter? And so this is just a figure to sort of drive that concept home. When you look at the relative risk of aortic dissection, and this is relative, not absolute risk, compared to aortas that are less than 3.4 centimeters, you can see that when they reach that size cutoff of 4 to 4.4 centimeter, you have a 90-fold increase in the risk of aortic dissection. And when you reach that cutoff of greater than or equal to 4.5 centimeters, your relative risk for aortic dissection increases 6,000-fold. So going through the first criteria, which are patients who have a positive family history, but are gene syndrome negative. So they're a heritable thoracic aortic aneurysm with no identified genetic cause. In these patients, they're recommended to repair the aorta if it's greater than or equal to 5 centimeters, or greater than or equal to 4.5 centimeters if they have high-risk features. And what these features are, I've copied here from the guidelines. So if they have a family history of aortic dissection with an aortic diameter of less than 5 centimeters, if they have a family history of unexplained sudden death at an age less than 50 years of age, or if they have rapid aortic growth, which is defined as at least 0.5 centimeters in 1 year or 0.3 centimeters in 2 consecutive years, these patients would qualify to having the repair done at a lower threshold. The next criteria or group to talk about are the syndrome positive or the gene positive patients with no syndrome. And so looking at syndrome positive patients, first off is Marfan syndrome. The recommendation here is 5 centimeters for repair or 4.5 centimeters with high-risk features. And some of those high-risk features here, it's a similar theme, a family history of aortic dissection, rapid aortic growth, so at least 0.3 centimeters per year, a diffuse aortic root and ascending aortic dilatation. And the last note is of marked vertebral arterial tortuosity. One of the other things that's noted in the guidelines is for patients who are contemplating pregnancy, who have aorta in that 4.5 centimeter range, it is reasonable to consider repair in those patients in light of their impending pregnancy as well. And one of the things that came up in the guidelines here as well, in patients followed by a multidisciplinary aorta team, the CSA to height ratio above or equal to 10 is reasonable to consider repair in these patients as they had favorable outcomes. The next criteria is for Louis-Dietz. No specific numbers that I could find here, but the general understanding is that surgery is based on the specific genetic variant that these patients have, how fast things are growing, family history, age, sex of the patient, extra aortic features, and finally, physician and patient preferences in this case. And to briefly talk about Turner syndrome, just as a note, with Turner syndrome, it's important to look for bicuspid aortic valve, which can be present in 15 to 30% of cases, as well as aortic coarctation, 7 to 18%, and other congenital defects. The management algorithm here is if the patient is above or equal to 15 years of age, you use the aortic size index, which we talked about briefly earlier. It's the ratio of the aortic diameter to the body surface area. And that's what you use to define the degree of dilatation and the risk of dissection in these patients. And so the algorithm is if you're at least 15 years of age with an ASI of at least 2.5 plus risk factors for aortic dissection, it's reasonable to consider these patients for repair. And what are those risk factors? As you can see here, that's aortic coarctation, aortic dilatation, bicuspid aortic valve, and hypertension. And so this is to pictorially represent that algorithm in terms of when to or how often to monitor these patients. So you can see here it first branches off to whether these patients have other manifestations, so coarctation, bicuspid aortic valve, and hypertension. We then split in terms of the size with ASI and whether the patient is low, moderate, or high risk. Patients who are low risk with no additional risk factors can be monitored by echo or MRI every 5 to 10 years. And coming all the way to the right of the screen here, those who have other associated risk factors, who have an enlarged ASI and are high risk, you follow them as close as 6 months to a year with MRI here and not echo in this specific case. So the next criteria or group to talk about are the bicuspid aortic valve patients. You'll notice here that the cutoff for intervention is a little bit higher at 5.5 centimeters, with the first two groups we talked about at 5 centimeters. And they also mention here utilizing the CSA to height ratio of at least 10 for consideration of repair is reasonable in a multidisciplinary aorta team. 5 to 5.5 centimeters, so a little bit of a lower threshold if they have additional risk factors, and that is a family history of aortic dissection, aortic growth rate of at least 0.3 centimeters, aortic coarctation, and that root phenotype where the root is a bit more dilated, aortopathy. They're also mentioning if these patients are followed in a multidisciplinary aorta team and they're low surgical risk, it's reasonable to consider repair in that lower threshold as well. Otherwise, relevant to the bicuspid aortic valve patients, if they're going to have a surgical valve repair or replacement, having at least a 4.5 centimeter dilated aorta is considered reasonable to repair in that context as well. And the last group to talk about is the sporadic or degenerative patients. So these are no family history and no gene testing or gene negative, if you will. Surgery for these patients is 5.5 centimeters and can intervene on at less than 5.5 centimeters if you've seen at least 0.3 centimeters per year of growth in 2 consecutive years, or at least 0.5 centimeters in 1 year, then surgery is indicated for these patients. Surveillance in these cases, they're saying with transthoracic, CT, or MRI after about 6 to 12 months. And if things are deemed stable, then you can stretch this out to as much as following these patients every 2 years. I just wanted to briefly go over aortic arch aneurysms, descending aneurysms, as well as abdominal, and then we'll go into the acute aortic syndromes. So aortic arch aneurysms is the least common thoracic aortic aneurysm. Less than 10% of cases involve the arch. And just to summarize the guidelines here, those who have symptoms attributable to the aneurysm and are deemed low or intermediate operative risk, open surgical replacement is indicated. In those who are asymptomatic with low operative risk, open repair when at least we reach that 5.5 centimeter cutoff. And the notes also indicate that if the ascending aortic aneurysm extends into the proximal arch, then it's reasonable to extend your repair with the hemiarch replacement in those patient cases as well. And commenting briefly on descending thoracic aortic aneurysms, consider repair again at that cutoff of 5.5 centimeters. The threshold of less than 5.5 centimeters if they have risk factors for rupture, and that I have here on the right from the guidelines. So again, 0.5 centimeters per year, a symptomatic aneurysm. They have other connective tissue diseases or genetic aortopathy, so Marfan's, Louis Dietz, etc. A saccular aneurysm, female sex, or an infectious aneurysm. There's also notes in the guidelines here that if the patient is of increased peri-op morbidity and mortality, it's reasonable to increase that size threshold for surgery. And some of those patient characteristics associated with increased morbidity include advanced age, CKD, pulmonary disease or COPD in this case, as well as previous stroke. And then very briefly to talk about abdominal aortic aneurysm, just for completedness, a repair is recommended when that maximal aneurysmal diameter is at least 5.5 centimeters in men or 5 centimeters in women. Otherwise, irrespective if they're symptomatic, you would repair. And if the growth is more than 0.5 centimeters in 6 months, then you would consider repair for the abdominal aortic aneurysm. So switching gears, I wanted to talk about aortic atherosclerosis. So aortic atherosclerosis, these are detectable aortic plaques, which indicates the presence of atherosclerotic disease. Of relevance to us is aortic atheromas are a possible source of embolism. And what an aortic atheroma is irregular intimal thickening of at least 2 millimeters. The prevalence increases with age and smoking, as we would expect with atherosclerosis. And at least 4 millimeters is associated with a significantly increased embolic risk. And where we see this embolic risk, particularly, are when these patients undergo procedures such as coronary angiograms. And with the strong association between aortic stenosis and aortic atherosclerosis, when these patients undergo their workup or TAVIs down the road, it's an important consideration to think about. And it's noted here that transesophageal echocardiogram is better to visualize these atheromas. And of relevance in the guidelines, they're saying if you have recurrent emboli from thrombus, of which aortic atherosclerosis could be one of the reasons, it's reasonable to consider anticoagulation if you've had recurrent strokes or limb ischemic events. So this is a still image showing the suprasternal view. You can see the ascending aorta and the descending aorta, and you notice here this echogenic material in the aortic arch, and this is showing you how an aortic atheroma would appear when you image. Okay, so now we talked about some of the more chronic things that we follow. Now I'd like to switch gears and talk about the acute aortic syndromes. So when we talk about acute aortic syndromes, there are 3 diagnoses that come. One is of aortic dissection, which is the most common. We have intramural hematomas, and then you have a penetrating aortic ulcer. So briefly talking about each of these, and we'll go into more detail with some pictures. Aortic dissection is based on the presence of an intimal flap that divides the aorta into the true lumen versus the false lumen. And you use color Doppler to identify the false lumen, but it can be absent if it's totally thrombosed or there's retrograde dissections. An intramural hematoma is characterized by circular or crescentic thickening of the aortic wall of at least 5 millimeters. Now, in this case, the blood leaks into the media, the layers that we talked about, so the tunica media, at a lower pressure, and it pushes that aortic wall outward. And so typically the integrity of the inner lumen, where the blood actually flows, is relatively preserved, typically speaking, when you compare that with a dissection. And when we're talking about a penetrating aortic ulcer, this is the picture of sort of a crater-like outpouching with jagged edges. The ulcer allows the blood to enter into the media, but because you have scarring related to atherosclerosis, that blood is typically confined to a certain area. And so it's a localized dissection or pseudoaneurysm. This is just quickly to go through some of the classification with the aneurysms, which become relevant in the overall management. You have the DeBakey classification with type 1 and type 2 involving the ascending aorta and whether it involves involvement distally. And you have the type 3, which involves the descending aorta, so distal to that subclavian. And if we go into the abdominal aorta, that's type 3B. A bit more simple in terms of classification is the Stanford. So type A involves anything that involves the ascending aorta, and type B involves anything involving the descending aorta. When we think about classic acute aortic syndromes, particularly that of acute dissection, the classic sort of presentation is ripping chest pain that radiates to the back. But you can imagine with the multitude of sequelae that can typically present, and we'll go through all of this with the imaging, there's a whole host of presentations that patients can present with, anywhere from dysphagia, bowel ischemia, hoarseness, Horner syndrome, hemoptysis, depending on the acuity, all the way down to paraplegia, shock, obviously, syncope, SVC syndrome, and stroke symptoms. And I've just listed this here just for your reference in terms of some of the pathophysiology as to why this happens, and we'll go through some of these of relevance later on. So in terms of acute aortic dissection, newer echo technologies allows for improved sensitivity and specificity for type A dissection, so sensitivity of 93% and a specificity of 97%. However, we're a bit more limited in type B involvement, where the sensitivity is down to 84%, specificity of 94%. Obviously, if patients have abnormal chest wall configuration, obesity, excuse me, pulmonary emphysema, or mechanical ventilation, your views are a bit more limited in that case. And so the guidelines recommend initially going with CT, given its speed, accuracy, availability, and anatomic extent or detail. And also realistically, when we're looking after patients, it's a combination of this where we put the probe on the chest to have a view and confirm things with CT scan based on their clinical trajectory as well. And so just practical points when assessing a patient with chest pain, keeping in mind an acute aortic syndrome on the differential. And so looking for aortic root dilation, looking for aortic regurgitation and or pericardial effusion. And we'll go through systematically. One concept just to talk about in terms of utilizing echo with dissection, we talked about this concept of a true and false lumen with that dissection flap. And so how do you differentiate between the true and false lumen? There are some criteria here from the guidelines that I just wanted to briefly explain. So one is looking at the size. Typically, the false lumen is often larger than the true lumen. We look at the pulsation. So in systole, you expect the true lumen to expand with systole as the blood flow goes through, and you expect systolic compression of the false lumen. When you look at the direction of the flow, you would expect antegrade or forward flow in the true lumen, but with the false lumen, you could have reduced forward flow, absent, or retrograde flow. Communication is between the true to the false lumen in systole, and with contrast, we expect early and fast flow into the true lumen, and it would be more delayed and slow into that false lumen otherwise. So this is just a brief clip just to highlight the concept of the true versus the false lumen. So you can see here that this is a peristernal long axis dissection flap here. If I weren't applying color, it'd be a little difficult to visualize where the true versus the false lumen is. And with applying color, you can see color flowing through here and not through this region here, and delineating this as your true lumen and that as your false lumen. And so you can just see that with the color there. So some still images from the guidelines that I thought were nice pictures to hit home some of the points. So these are some transthoracic echocardiogram views showing an acute aortic dissection. The concepts here to note are, you note the dissection flap. So panel A is showing you the aortic root in the peristernal long axis view. And you can see they're showing you a dilated aorta, aortic root, as well as the dissection flap here. In panel B, you see the aortic arch and the distal ascending arch here as well, with the arrow indicating that dissection flap here as well. In C, you see the proximal descending aorta. This arrowhead is showing you that entry tear, and applying color, you'll be able to see that this is the false lumen and flow going into here as the true lumen. And the last view here is that of the abdominal aorta. Color has been applied again to show the concept of this being your true lumen and your false lumen being here, with some secondary communications noted with the small arrowheads here. So where does transesophageal echocardiogram fall into play with aortic dissection? The benefit with transesophageal echocardiogram is you can image the entire thoracic aorta except for a small portion of the distal ascending aorta near the proximal arch. The sensitivity is 86 to 100%, specificity 90 to 100, and a negative predictive value of 86 to 100%, again, operator dependent. And so essentially what the guidelines boil it down to is transthoracic echo can be used initially in the emergency setting. However, before surgical intervention for planning purposes, a TEE should be sought. And if you're doing or working up a type B dissection, so this is what we talked about with the descending aorta, a transesophageal or CT scan should be performed in patients suspected with a type B. And this is a still image showing you on a transesophageal echocardiogram, the ascending aortic arch. It's showing you a dissection in the long axis view, delineated by the arrows here. And this is a descending thoracic aorta dissection in the transverse view, with color being applied, where you see the true lumen and the false lumen here, with the arrows showing you here and here the point of the intimal flap. So now going through some of the complications of acute aortic dissection and how echo falls into play with this. So the first to talk about is a pericardial effusion. And this figure, I thought, that visually depicts the concept. When you have a tear in the wall of the aorta, you can have blood flow into the pericardial space, which can present as potential tamponade in these patients. However, it's not always due to blood from the aorta. You can actually have irritation secondary to the hematoma, where it irritates the adventitia, or it could be a small effusion from the wall itself. Regardless of the etiology, it's a poor prognosis to have the presence of a pericardial effusion, and it suggests possible rupture of the false lumen into that pericardial space. And obviously, echo is the best tool for us to assess for the presence, as well as the severity of cardiac tamponade in these cases. Another important thing to look for in terms of complication associated with aortic dissection is that of aortic regurgitation. It occurs in up to 3/4 of patients who present with the dissection. You can use your color Doppler to assess, Doppler to assess the severity of this. And where transesophageal echo plays in is you can look at the mechanisms that affect the aortic regurg, which will also particularly help with surgical planning for these patients as well. And just for completedness, there are various mechanisms by which you can get significant AI in patients with dissection. And just to go over these briefly, one of the mechanisms is you can have the actual annulus, because of the dilation of that, because of the dilation of the ascending aorta, you can get regurgitation through that. You can get rupture of the annular support and tear in the implants of one of the valvular leaflets. The hematoma itself can cause asymmetric dissections, and it can displace a sigmoid below the coaptation level of the valve. You can have prolapse of the intima into the outward part of the LV as well through that valve orifice. And obviously, previous aortic valve disease can also play into account for the aortic insufficiency that these patients can present with. So this is a clip, a mid-esophageal TEE view, outlining to you the aortic insufficiency. And then without the color, you can see the dissection flap just distal to the aorta here. And this is just to show you that dissection flap, as well as the significant AI that you can get in these cases. And the other thing to think about in terms of complications with aortic dissection is that of arterial vessel involvement. So diagnosing this and being aware of this is important, as it can explain some of the symptoms or other complication that the patient presents with. And similar to the patient that I saw while on call, about 15% of patients can present with coronary artery dissection, the RCA being the most commonly affected. And practically for us on echo is to look for regional wall motion abnormalities when doing a transthoracic study. And the TEE can help to visualize the proximal segments of the coronaries to see if there's involvement there. The suprasternal view is also helpful, looking at that aortic arch and the main blood vessels feeding the head, as well as the upper limbs. And if you're looking for things in the abdomen, precisely with renal or iliac artery disease, CT and MRI is more precise in those cases. And when we talk about some of these quote-unquote malperfusion syndromes, these are some of the findings that we look at. So with cardiac, you see findings of ischemia or infarction, troponin elevation or myocardial dysfunction. In this case, it can mimic essentially a code STEMI. Cerebral findings, so stroke, neurologic deficits, and altered mental status. Paraplegia with spinal end organ dysfunction. Mesenteric, you can get abdominal pain, ischemia, etc. Renal dysfunction, you can get AKI. And then with extremities, you can lose your pulses in your extremities or sensory or motor dysfunction. So now talking about the next aortic syndrome, acute aortic syndrome, is an intramural hematoma. So this is the presence of blood in that medial layer that we talked about of the aortic wall in the absence of any overt intimal tear or false lumen. And the idea with this is rupture of that vasovasorum, which we were talking about, in the lining of the aorta, causing blood to go into the media, or they could be small intimal tears that we're not visualizing based on standard imaging. It's that circular or crescent-shaped thickening, at least 5 millimeters, in the absence of detectable blood flow. Less than 10% of these resolve spontaneously, then you have a risk of progression to dissection if that intimal layer ruptures. This is a non-enhanced CT image showing you an intramural hematoma, which has been delineated with the arrows here, showing that here it's about 11 millimeters in size. What are some high-risk features of intramural hematoma? So type A versus type B, so again, involving the ascending versus descending. The main concepts here is the diameter of the aorta, the thickness of the hematoma, whether there is a pericardial effusion, and whether the integrity of the intima is disrupted with an ulcer-like projection. And so if you have these high-risk features, regardless of type A or type B, urgent repair is indicated. Uncomplicated, so none of these features with a type A involvement of an intramural hematoma would require urgent repair. And uncomplicated type B is medical management. And how, when perusing through the guidelines and some of the literature, is essentially with beta blockers and ACE inhibitors or ARBs. The next acute aortic syndrome to talk about is the penetrating atherosclerotic ulcer. So this begins with an atherosclerotic plaque. You have some disruption in the aortic intima, which allows that blood to go medially. Most often this occurs in the middle or the distal thoracic aorta, and up to 7% of acute aortic syndromes can be attributed to this. Typically, you see these in older individuals because of the burden of atherosclerosis and that involved in the pathophysiology, but it can occur in younger individuals if they have some inflammatory or connective tissue disorders. The natural history of this condition isn't really well defined, but the general broad strokes is if there's a rupture, you would repair. If it's associated with an intramural hematoma in the ascending aorta, you would repair these cases as well. If they're symptomatic or asymptomatic with high-risk features, you would repair these patients as well. And this is a TEE still image showing you the descending aorta. You can see this echogenic atherosclerotic plaque here and a disruption with an ulcer-like projection into the intima, and this is how a penetrating atherosclerotic ulcer would be visualized on TEE. You can't really see these on a transthoracic echocardiogram otherwise. Excuse me. In terms of the high-risk imaging features of a penetrating atherosclerotic ulcer, we won't go into the nitty-gritty of this, but the guidelines talk about a whole bunch of dimensions and measurements. They look at the diameter, the depth, they look at the inner aspects here. So just to show you the concept, they look at the maximal aortic diameter, they look at the depth of that intramural blood pool. Oops. They look at the length of the intimal defect, and they also look at the width of that blood pool as well. All of these factors, along with other things such as increasing pleural effusion, saccular aneurysms, play into whether these are high-risk imaging features or not. So now that we went through all the sort of stable aortic pathologies, acute aortic syndromes, and the role of echo in these cases, I just wanted to summarize, and this is a nice table in the guidelines, commenting on the role of each of the imaging modalities. We'll start with transthoracic, transesophageal, and work our way with CT MRI. So the advantages of transthoracic echo, as we discussed, it's often one of the first tools that we can reach for when looking after undifferentiated sick patients, and it can give us a lot of information regarding LV contractility, pericardial effusion, assessment of tamponade, RV size function, as well as looking at the severity of AI. However, with transthoracic, we're not able to see as well distal to the aortic root, and we're not able to visualize, as I briefly mentioned, intramural hematomas nor penetrating atherosclerotic ulcers. Where transesophageal echo falls in is very high diagnostic accuracy. You're able to visualize a lot of the aorta, except for that blind spot we briefly talked about in the upper ascending aorta and the proximal arch. You can assess for pericardial effusion, the mechanism of AI, which we talked about, as well as the LV function, and you can also see if the coronary arteries are involved as well. This is something that you can do, obviously, in vented patients who are sick, and it also helps with operative planning as well for these patients. Some of the disadvantages, obviously, operator dependent. You can have artifacts that can potentially mimic a dissection flap, and it's not reliable for your cerebral vessels and your abdominal vessels otherwise. CT, in terms of our practice, we see as one of the most commonly used imaging modalities for these patients. It's widely available, very quick diagnostic time, relatively operator independent, other than obviously the interpretation. And the benefit of CT is with one test, in a few minutes, you can visualize from head to pelvis and look at the entire aorta, including all of the other main blood vessels, to see if there's any other sequelae from this. Some of the disadvantages are radiation and some artifacts that you can get in the ascending aorta otherwise. And lastly, really with MRI, very good diagnostic accuracy, but not very practically feasible, very essentially impossible to have a critically unwell emergent patient to be in the scanner for that period of time. And it's not really a feasible study to use upfront in these patients. And then angiography, we've never really used that for the acute diagnosis really here. Often it misses an intramural hematoma, and it's obviously a long diagnostic time, and it can increase the morbidity with less sensitivity compared to some of the other imaging modalities that we have. And this is to pictorially sort of represent that point from the guideline here, with 1+ sign being fair performance, 2+ signs good performance, and 3+ signs showing excellent performance. And the overall themes with transthoracic and transesophageal echo, as you can see here, good availability and portability, the speed of acquisition, spatial and temporal resolution is excellent, and one is able to evaluate the valve and the ventricular function well with transthoracic and transesophageal echocardiogram. Where the CT falls into play here are some of the themes we talked about earlier, being able to visualize the entire aorta, as well as the other sequelae with the major arteries that you can visualize relatively quickly here as well. So going through the objectives just to solidify the point. So we've reviewed the aortic anatomy. We talked about the steps to acquire the images and the protocol to acquire the measurements for the aorta. We looked at the guidelines on monitoring and interventions for various aortopathies, whether that's patients with syndromes with Marfan's, Turner's, or Louis-Dietz, those who have a heritable family history but non-syndromic, those without any family history or that are gene negative, and finally those with bicuspid aortic valves as well. And finally, we reviewed some of the acute aortic pathologies, with aortic dissection being the most common. We reviewed intramural aortic hematomas, as well as penetrating aortic ulcers and the role of echocardiography in these cases, and particularly with some of the sequelae with aortic regurgitation, with pericardial effusion, as well as looking for major vessel involvement, including coronary involvement, which is where oftentimes we can get called with these patients as well. So along with all the embedded references, these are some of the references from the guidelines. And that ends my talk. So thank you very much. Hope that was helpful for you all. Thank you.
That was an excellent review. Thank you very much, Sivi. And I'll say to the cardiology residents in the room, a lot of what Sivi presented is very relevant, high yield information and preparation for the exam. So I thought that was excellent. With that, we can open the floor if there are any questions.
just going to make a comment. Yeah, great talk, Sivi. In regards to sort of proximal dissection and TE for the assessment of coronary arteries, we look, but it's by no means diagnostic, and you'd want to back it up with angiography or other CT. We obviously try to track the coronaries. Typically, if you see the effusion, we look to see if the right's sheared off.
Right.
The left is a little less likely to happen, but sometimes the dissection flap, if it's really proximal, might prolapse in and cause occlusion, but it's not really diagnostic enough that you would always want to back it up with more imaging there. There's no studies, of course, to support this. This is all what we call eminence-based from the sort of big folks who have run the big aortic dissection work. So again, complement it with other modalities then.
Absolutely.
I actually just have a question about that. So in proximal dissection, do you get dissection flap blocking the coronaries, or do you get dissection down the coronaries, or both?
Well, you can get both, right?
Yeah.
So we've had a couple of cases where we've seen the dissection flap actually cross the aortic valve and result in aortic regurg, flap in and out of the left main, but you can also, typically it's the right coronary. I don't know why it's the right coronary, whether it's pressure or something else, that it's typically the one that can actually be dissected off, and you'll present with right coronary ischemia. So the syndrome is the acute chest pain that then evolves into a pericardial effusion and a STEMI. Just keep it in the back of your mind that there might be that. This is very unusual. I mean, typically for these dissections, the presentation is generally quite different from, we're talking hypertensive atherosclerotic disease, and usually the key feature is the back. Right? People have this rolling around, uncomfortable. They don't look like an acute coronary event where they tend to sort of clasp their chest. And again, this is not, it's just observational of seeing these folks. And they're usually in the presence of hypertension, right? It's the elderly hypertensive folk there. The other thing is, we do have fairly rapid genetics. So if you really are worried about any of these things, we can get SAM. There are actually saliva tests, which we can turn around in days. We generally only reserve those for pregnant women, in which case we might have to recommend termination if there's a family history of Louis Dietz or something like that. But it is actually available to get done because obviously the impact on your management is acute there, right? So if in doubt, there are options to turn that around. Really within a week would be about as quick, but you can push it maybe 2 to 3 days, not really worried. As I said, generally that's pregnant women that we're then like, what are we going to do here? And usually we then, do urgently call the high-risk pregnancy group at Sinai or Joel Ray here, but there is that opportunity if you're worried. Yep.
It's probably more common that you get dissection into the coronary artery, or at least involving the os with the occlusion as opposed to the flap causing obstruction.
Okay. Just curious.
Just a quick question about follow-up. One of our most challenging question and is actually how often we follow up patients and when do we start following up patients in terms of mild aortic dilatation. Typically they're like 38, 39, 40 in the proximal ascending aorta, or maybe 41 to 42, 43 in the aortic root. Have you read anything about how often we should follow up patients?
So not really a clear answer, because I was trying to understand this as well. They essentially say initially following up as close as 6 months, and if clinical stability, you can stretch this out to as much as wide as 2 years. The practice that I've seen from my experience thus far rotating through the hospitals is patients are followed about a year's worth, but that's essentially what I was able to find throughout the guidelines.
Yeah, typically we follow up patients with mildly dilated aorta once a year initially, and then if stable, then we follow every 2 years. But I think the guidelines people from various different national groups are very hesitant to actually come up with a unifying follow-up guideline. So this is what I noticed. Right,
yes.
Yeah, it would be an area where like a risk calculator would be very helpful. Like, because a lot of it relies on doing a short-term interval, repeat echo in 6 months, 12 months, see what the rate of growth is, and then clinical judgment after that in terms of follow-up. So like a risk calculator might be really, really helpful here. And